Dr. Michael Fine, the former director of the Department of Health, is in the studio today. Dr. Fine, appreciate your coming in.
Nice to be here. Nice to see you.
We had just chatted recently, and here we are a couple weeks later with some big news with the exploration of the merger with Care New England and Partners. And you bring a unique perspective, having been, I don't want to say knee-deep, kind of chest-deep in all things healthcare here in Rhode Island. I just wanted to get your perspective about this. We just had Chris on talking about his from the UNAP standpoint, which represents his membership. But maybe talk a little bit, I mean, you've probably, as he kept on going and saying the tea leaves, I'm sure this did not come as a surprise when you saw this. But what was your reaction to it?
Well, I think my reaction is that this represents, in a certain way, the failure of health policy in Rhode Island. What we need to do is get to a healthcare system that's the right size,
okay,
that takes care of people effectively, efficiently, and affordably. And to me, this means more cost and less efficiency. It means more cost because Partners is a very expensive institution. And I think that they have the ability to use their market power to drive costs somewhat, which is dangerous for the state. The Prime, the new purchaser, the potential purchaser of Memorial, also will work hard to keep hospital beds open and hospital beds filled, and those hospital beds create costs themselves. Turns out that there's no real evidence that the number and location of hospital beds have any impact on public health outcomes. And what we need to do as a state isn't to maintain hospitals, but to shrink them. We probably need to close 2 or 3 or 4 hospitals if we're going to get to right size. And there's no political appetite for doing that, which is our challenge. What we really need to do is find a way to reduce costs so that healthcare in Rhode Island is more affordable than healthcare in Massachusetts and Connecticut. And we haven't done anything to get us there.
And you talk about the political willpower of doing so. Is it almost an insurmountable hurdle that someone will have that sort of political courage to do something and make that? Because we're talking, when you talk closing hospitals, of course, the reaction is jobs, jobs, jobs. Unions get involved and things of that like. I mean, could it even be feasible?
Well, it's feasible from a healthcare perspective, but in Rhode Island, difficult as heck from a political perspective. And that's something that I think we need to look at ourselves. We need to look at ourselves and understand why we can't do what's in the best interest of the public.
Have we just created this sort of healthcare industrial complex monster that it's almost impossible to untangle?
Well, unless there is someone who can develop the political will to change it, it does seem exceptionally difficult to untangle. You're right. When we think about hospitals, what we think about is jobs, not public health outcomes. And yet when we buy health insurance, which is becoming more and more unaffordable, what we want is improved health outcomes.
And you said the number of hospitals and or location of the beds there's no definitive proof about effects on public health outcomes. Do you think the public is led to believe that, or sort of misled to believe that by hospitals?
Oh, I think it's clearly in hospitals' interest to frighten you into using their services when we know, for example, that about 50% of emergency department visits in Rhode Island are what are called ambulatory sensitive. That means they're basically unnecessary. At least 11 or 12% of inpatient hospital stays are unnecessary, and many of us think that number is more like 30, 40, or even 50%. We overuse this system over and over and over again in order to create income and profit for individuals and corporations at our expense and peril.
And we talked a little bit about with Chris just prior to this announcement of this exploration of the merger, the role that Lifespan has played. Just the week before, they were making overtures that they were sort of in talks with Care New England. Obviously, we saw where this ended up. Do they still have a role? And one of the things that we had spoken with Gary Sass about, could they even, and from a monopoly standpoint?
Well, I think if we could begin to think about hospitals as a sort of public asset instead of as private entities, we might think about this differently. 64% of hospital income is public, from Medicare or Medicaid or Veterans Administration, something like that. So we are actually together paying for these services with public dollars. And yet we let these institutions function essentially on their own, competing with each other, trying to drive business, and that driving of business increases the cost. Could you put Lifespan and Care New England together? Of course you can. I mean, if you think about it, we have a monopoly on electric power. We have a monopoly on water. There are legal ways of getting monopolies oversight, and particularly when it's in the public interest, and that we have failed to do that is a failure of public policy in the state of Rhode Island. We are too small to have competing hospitals and hospital systems. So somebody, if we were serious about health policy, somebody ought to say, gee whiz, let's figure out a way to make this work. You know, the dirty little secret, or maybe the best little secret about healthcare in Rhode Island is the tunnel that connects Rhode Island Hospital and Women and Infants Hospital. Clinicians at both institutions have been collaborating for 40 years. We work together and have produced pretty good health outcomes as a result of that work, but the business enterprises are tearing us apart. We all need to look at that and change it.
And who does this have to come from? Does this have to come from the governor down? Does this have to be bringing all the stakeholders to the table?
Well, personally, I think I think the best people for it to come from are healthcare workers.
Okay.
Not just one union or another, but all of us who work in this marketplace, because it's not a system, all of us who work in this marketplace understand what it's doing to patient care and understand what it's doing to cost.
Yes.
And if we don't revolt, if we don't find a way to get together, stand up and change it, then it's never going to change. So strangely, I think this is the moment and opportunity for healthcare workers to learn to work together in a new way and change this.
And you say that, does this come, I mean, you're a physician, so some healthcare workers have unions, some don't, and you're a busy guy, so do you see an appetite for health care individuals to do this? Because as you said, we're really at a dire point in time here.
I don't see an appetite, but I also don't see a choice. You know,
you got to eat your spinach.
Yeah, basically. I mean, you know, if you think about it, if you talk to a nurse or a doctor or any hospital worker or anybody who works on the front desk of a primary care practice or a community health center, everybody's miserable. We're all doing good work. We're all doing important work, but our lives have been taken over by different kinds of business interests and decisions that don't have much to do with sitting at the bedside of a patient. Oh. That's not going to change unless we change it.
And what would you see if we do end up going down this road with a partners merger? You did speak to the exorbitant costs that you would see associated with it. You know, if you had the crystal ball, what breaks, what gives if this happens and, as you say, can't be sustained?
Well, I think the first thing that gets difficult is the experience of Rhode Islanders who need certain kinds of specialty care, which will suddenly be available only in Boston. And I don't know what your experience of Route 95 is, but I don't think that's going to be fun for many people. Having to go up to Boston for certain kinds of work, and we'll also see the transfer of a number of highly paid jobs to Boston where they really ought to be here. That's the first thing. I imagine that we will rapidly see the disappearance of Butler, because I'm not sure that Butler really has a role at this point. Only we don't really have the public courage to address that, as good a place as it is. But remember, the technology has changed and the needs have changed, so I'm not sure you'll see the same accessibility to services, a variety of sorts. And when things shrink here, that means the service availability will tighten up. So you'll see longer lines. You know, you're beginning to see that now as Memorial is shrinking. You know, Miriam is full up to its eyeballs. And access to care becomes more difficult unless we develop some wisdom in health policy and start building up the primary care delivery system, which we really need and which is crucial if we're going to unload the hospital system, and crucial if we're going to save money and improve public health outcomes.
So what needs to be done to build up the primary care system?
Oh, that's an organized investment that the state can or should make. Whether the state will make, we've not made it yet. But my guess is as things tighten up, remember what Winston Churchill said about us? We usually do figure out the right thing to do after we've tried all the other ones. When, care becomes incredibly expensive. It's expensive now, unaffordably expensive now, but when care becomes unaffordably expensive, when you have to drive up 95 for certain kinds of procedures and tests, when other institutions find themselves in trouble and access to care declines, then one hopes we would develop the wisdom to build the primary care delivery system that we so desperately need.
And you say an organized investment. To the average layperson, what does that mean?
Well, when I was at the department, we put forth an idea called the Primary Care Trust. That would be one way to do it, where we pool all the money we have to spend on primary care into a funds consolidator, and then in a focused and intentional way, build one robust primary care practice for every 10,000 people. We have a backbone of practices that look like that. Our community health centers look pretty much like what we ought to be doing. A number of larger private practices do the same kind of thing. The Bristol County Medical Center is a prime example of how you can do this and do it well, where you put 90% of the services each community needs in one place. Sort of like the old Riga model, so that people don't have to work very hard, and you keep it open from 8 o'clock in the morning till 8 o'clock at night, and open on weekends, and you set it up so that if people are sick today, they're seen today. It turns out to be that this is inexpensive and not very hard to do, but you need an organized approach to doing it. And one hopes that someday we might find our way there after we've tried all the other attempts that have come close to bankrupting us.
And you did mention in previous comments about Butler and the role of Butler struggling. Why is Butler struggling?
Well, it's actually struggling, I think, mostly because of competition from Rhode Island. Rhode Island has built up a very robust psychiatric inpatient facility, and so we end up with two, and in a state where we really need one. That's the kind of thing we're going to see. Rhode Island Hospital wants to build a maternity suite,
yes,
and that will weaken both Rhode Island and Women and Infants. Women and Infants is the 7th busiest delivery hospital in the United States.
Wow.
It is from the perspective of the Rhode Island medical business enterprise, it's a gem if we treat it right, develop it right, and invest in it, which we haven't really done.
And what would happen with partners with, let's talk about research and university institutions? They have close ties to Harvard Medical School. What happens to Brown?
I think that's a really difficult and open question. I think Brown in many ways relies upon the existence of both Lifespan and Care New England, and to have one torn away, I think you'll see a period of transition, but then consolidation, and I'm not sure how viable that makes the medical school long term.
Do you think they have serious concerns at this juncture with this news?
If I were them, I would. I think they've been worried about it for a long time. And that's where we've missed this opportunity. The opportunity was to combine Rhode Island, to combine Lifespan and Care New England, wrap the medical school into that process, develop a great primary care infrastructure, and come out with a healthcare system that produces the best outcomes at the lowest cost and builds jobs in Rhode Island. And we have totally failed to do that.
So you were the head of the Department of Health and oversaw so many things health related, and the hospitals and the healthcare industry was one portion of that. Do we need sort of a healthcare czar, if you will?
Well, I actually like it's a brilliant question. I actually think we need to create a Ministry of Health instead of a Department of Health, into which we put both financing, measurement, and a responsibility for the delivery system. No other state has done that, but that's the way it works in other countries that have great outcomes at low cost. If we don't do that, and, we have our Medicaid spending is incredible leverage to shape the delivery system. We've never used it. There are many opportunities that we have that we've let kind of escape us.
And as you said, if there wasn't a point in time of which to address these or to even consider them, now is the point, is what is basically pointing out.
Well, it's been, some of us have been thinking about this for 15 or 20 years. And every time we get to a merger, we have the same thought. The notion of the primary care trust actually came out of discussions at the Rhode Island Foundation at the time of the last merger, thinking that what we ought to do is sell off Butler, take the money from the Butler campus, use it to capitalize the primary care delivery system as we brought Rhode Island and Women and Infants and Care New England and Lifespan together. That's health policy, but we haven't been able to get it done.
Any other things to consider as we look here moving forward? And we just did hear that they just entered the very beginning stages of exploring this merger. And as Chris and I were talking about, the time frame is protracted if they even come to a deal at all. But if you're the average Rhode Islander who might not be working in the healthcare industry, what would you say to keep an eye on as this process moves forward?
Oh, I don't think there's anything easy to keep an eye on. You kind of have to watch the daily newspaper. But, the thing that I'd be doing if I were the average Rhode Islander, I'd be talking to my state senator or state rep and talking about cost. Most people don't know that in 2003, families spent about 17% of their income on health care. Mm-hmm. In 2017, it's 30%.
13 to 30.
17 to 30, I'm sorry. The projection from the Congressional Budget Office is that by 2025 it will be 50%, and somewhere between 2031 and 2038 it becomes 100%. Now you tell me how those economics work.
Those economics don't work.
If people don't start speaking up and speaking out, basically they're transferring all their income and wealth to somebody else. Healthcare becomes not a healthcare system, but a wealth extraction system, and we can't afford it anymore.
Who does it well, in your opinion, if we look at a worldwide view? And is it a hybrid of bits and pieces of different areas, of different countries of what they do, or?
Well, I think most countries do it pretty much the same. We're the outlier. So Finland does it particularly well. Israel does it well. Norway does it well. Spain does it well.
But do you have the knee-jerk reaction of folks say, "Oh, but that's socialized medicine"?
Well, but I ask people to think about: do we call fire protection socialized fire protection? Do we call police protection socialized police protection? These are terms that are meant to make people scared and let people with something to sell keep selling it, and let people or force people with not enough money to have to give their money to somebody else. It's time. We're smarter people than this, and it's time for us to stop being stampeded by language that really doesn't matter anymore. To his credit, Bernie Sanders walked around and said, I'm a socialist, and the world didn't explode. Now I'm not a socialist. But I think it's okay for us as a people to have a coherent, thoughtful, informed discussion about policy, looking at what's really happening, not just being stampeded by people with something to sell.
And one of the things that we had talked about, as I said, we had just talked in recent weeks, and I do kind of want to finish the conversation on this point. Marijuana legalization. This is something we had spoken with Dr. Fine about, was prepared to be on board in support of the current legislation, but having gone through, took major issue with the fact that cities and towns can't opt out of having sale of legalized marijuana in their cities and towns. Of course, we've seen a lot come out since then. They had the hearings. We did initially hear from department heads in the Raimondo administration of having issues. Then the governor herself basically said, well, look, maybe we should take a pause on this. What's your thoughts? Do you think it just, again, we're going to be putting this on the back burner for now?
But I don't think it's going to pass this year. But, marijuana policy and substance use policy is complicated. but it bears reasonable, careful thought. On the one hand, you want to get rid of black markets because they cause a kind of social cynicism. You know, we make something illegal that everybody uses anyway, and we put some people in jail, most of whom turn out to be people of color. What's that all about? On the other hand, Rhode Island struggles with use. We have use rates of every substance we measure that are in the top 5 of the nation. So we have to find a way to thread a difficult needle. We want to sort of not make illegal something that's, you know, commonly available, but we also want to have the resources to help people in their communities not overuse, to use judiciously, and to make sure that the people who are susceptible to addiction, about 10% of the population, are protected against addiction and have immediate access to treatment should they become addicted. That's complicated. And so, you know, my position was, let's legalize, but then let's let local communities have control and restrict access to sale. You know, we'll never get it perfect, but we'll eventually get it better. But I think it'll take another year or two.
And does the state, as we stand here in 2017, do you have faith in the ability of the state to oversee something as complicated as this? When we're looking at major problems with the UHIP system, which is something separate altogether, DMV, 911 system went down the other night. Right. Do we have trouble with things on a large, broad scale?
Hard for me to answer that globally, but I think we can learn. You know, we have great people, and this is an amazing place to live. If we put our heads to it, there's nothing we can't do. And, you know, healthcare, which sounds hugely complicated, and marijuana, which sounds a little complicated, these are solvable problems compared to some of the problems that exist elsewhere in the world, as long as we remember that we're in this together and we put our heads together.
So Dr. Fine had reached out to me and said, if you do another piece on hospitals, I want to talk with you. So we got you in, picked your brain on a number of issues. Is there anything that we haven't touched upon that you want folks to know about?
I think we did a pretty good job covering the ground.
Covering the ground, again, is big shakeups, potential shakeups in the healthcare world here in Rhode Island are afoot. Was able to get Chris Kalachi with the UNAP and, of course, former director of the Department of Health, Dr. Michael Fine, to get some perspective here for viewers. Very much appreciate your coming in today, Dr. Fine. I'm sure we will talk soon in the coming weeks and months. So
thanks, Ray.
I'll let you scoot out. I know you're a busy guy.
Thanks.
And we'll talk shortly. Everyone, that was Dr. Michael Fine, the former director of the Department of Health. Started off with a very bold statement here in the Navigant Credit Union Broadcast Center, which was that he saw the potential merger or acquisition of Care New England by Partners Healthcare as a failure of healthcare here in Rhode Island, and went in to explain why, talking about sort of the political will he said he sees as necessary to have the healthcare system here at, I don't want to say as we know it, he would say that there needs to be major shakeups to even to survive here in Rhode Island. A very, very interesting conversation with the always interesting and engaging Dr.